Okay. All right. Welcome to the ADAA webinar, My Child Has Mood Swings. How do I know if it's bipolar disorder, and what do I do? My name is Katsuya Mokrua, and I'm a clinical psychologist as well as an assistant professor in the Department of Behavioral Sciences at York College in the City University of New York. I'm also the director of the Stress Less at York Research Program and a member of the ADAA Public Education Committee. I want to welcome you to this webinar, which is rescheduled from an earlier seminar, and we'll be able to answer some of your questions at the end of the presentation. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of the panel, and when you click in it, you can type in a question, and then either hit the Enter key or click the icon. And you can ask questions at any time, and we'll try to get to as many as possible. Other participants, just so you know, cannot see your questions. We may not have time to get to your individual questions, so we apologize if that is the case. We'll also be recording this webinar to make it available on the ADAA website at a later date. We are broadcasting, so we cannot control your individual audio or visual computer settings. Today we'll be hearing from Dr. Amy West. And Dr. Amy West is an associate professor and clinical child psychologist at the Pediatric Mood Disorders Program, Department of Psychiatry at the University of Illinois at Chicago. Before we begin, though, I'd like to tell you about ADAA. It was started in 1979, and today it is the leading nonprofit dedicated to increasing awareness and education about anxiety disorders, depression, OCD, PTSD, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they are real, serious, and treatable. So please visit the ADAA website. That's www.adaa.org, which includes Find a Therapist, which is a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can also support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Remember, you can type a question at any time. And now let me turn it over to Dr. West.
Thank you so much. I'm delighted to have the opportunity to speak today about pediatric bipolar disorder. I thought I'd start off by giving you a little bit more information about me and what I do. I am a clinical psychologist, and I specialize in pediatric mood disorders. So I spent approximately the last 10 years working clinically with children and families affected by depression and bipolar disorder, and also studying psychosocial treatments, and specifically psychosocial treatments for pediatric bipolar disorder, or PBD, as I'll call it. And, in particular with these treatments, our aim is to really help children and families manage the symptoms of bipolar disorder and to increase their psychosocial functioning and overall quality of life. So with my team of colleagues here at UIC, we've developed a treatment called Child and Family-Focused Cognitive Behavioral Treatment, also called Rainbow Therapy. And we recently tested this therapy through a randomized clinical trial and found it to be a very effective treatment compared to kind of standard of care treatment as usual for PBD. So my hope for today is to provide parents and others listening with information about bipolar disorder in kids, and then talk about various important psychosocial interventions that may help to reduce mood symptoms and increase overall psychosocial functioning. So more specifically, today I plan to provide some information about the symptoms of PBD and how it's diagnosed, talk a little bit about how to recognize mood symptoms in your children, and then talk about our rainbow therapy and in general offer some specific psychosocial techniques and tools that might be helpful. So I want to talk a little bit about the spectrum of mood symptoms that children can experience. So mood symptoms do exist along a continuum, kind of ranging from severe depression to extreme mania, with lots, various levels of mood symptoms in between. Bipolar I disorder describes patients who have experienced both a major depressive episode and a manic episode. So these are kids who've kind of experienced mood states at both extreme ends of the mood spectrum. Bipolar II disorder describes patients who have experienced a major depressive episode and some mania or hypomania symptoms, but have not experienced a full manic episode. So have not met criteria for a manic episode, according to our diagnostic criteria. So this means they may have had some symptoms of mania, but they were never intense enough or long-lasting enough to be considered a full episode. Bipolar II disorder is actually relatively rare in younger children. We really see this more in late adolescence and in adulthood. Cyclothymia describes patients who experience episodes of depressive symptoms and episodes of mania symptoms, but none that meet criteria for a full major depression or a full mania. So kind of those kids who vacillate between kind of subthreshold or lower levels of mania and depression symptoms. And finally, when children are experiencing some symptoms of depression and some symptoms of mania, but none of these symptoms meet the formal, psychiatric criteria for full episodes, they're often diagnosed with unspecified bipolar disorder. Unspecified bipolar disorder is extremely common in children, and we'll talk about why that's the case in a few slides. Most children who are diagnosed with bipolar disorder are diagnosed with either bipolar I or unspecified bipolar disorder. So I'd like to note that, as many of you are probably aware, for a long time there was this myth that children could not have bipolar disorder, that it only happened in adulthood. It's always been slightly puzzling to me because, we know now that these are brain-based, disorders that have kind of genetic components and biological components, and so it makes much more sense to me that, these symptoms would kind of develop over the course of childhood and adolescence. It's not as if we kind of magically receive a new brain when we turn 18. So thankfully, we do now know that children can indeed be diagnosed with bipolar disorder. We have lots of good research and 20 years of data at this point to validate that it is a diagnosis that can be assigned to children. And in fact, recent international epidemiological data suggests that about 1% of children experience kind of classic, bipolar disorder, and up to 13% experience subthreshold symptoms. So some symptoms of mania and depression that are episodic, and though they may not meet full criteria for a bipolar I diagnosis, are still nonetheless very impairing and very concerning and clinically significant. So the good news is that this has led psychologists and other researchers to begin to develop and research effective treatments for PBD. So pediatric mania is diagnosed when a certain cluster of symptoms are present. So first, the child must experience either elevated or irritable mood. And we'll see some examples of what that might look like on the next slide. But in addition to kind of one of these core mood states, core features of the bipolar diagnosis, the child must also be experiencing at least 3 or 4 of these other symptoms of mania. It's 3 if they have elevated or expansive mood, and 4 if they have irritable mood. So grandiosity means that they demonstrate an inflated sense of self and their abilities. So for example, these kids may describe having superpowers or consistently talk and act like they're smarter or more athletic or more attractive, or just in general kind of better or more superior to everyone else. Constant goal-directed activity describes when children become obsessed with games or other activities and really have trouble stopping or slowing down their activities, kind of doing a million different things at once and difficulty transitioning between activities. Excessive pleasurable activities describe when children excessively and kind of inappropriately engage in pleasurable activities. So often this manifests as hypersexuality, with children inappropriately touching, making advances, masturbating excessively and in public. But in general, children may have a lot of difficulty disengaging from activities that are pleasurable to them and curbing their impulses. Children may also be highly distractible and have difficulty concentrating. Parents may describe them as extremely hyperactive, kind of all over the place, bouncing off the walls. Decreased need for sleep is when children appear to have very little need to sleep. So they may sleep 2 to 4 hours a night and not seem tired the next day. So it's different from just kids who have sleep problems or insomnia or sleep disruption, but then are, very exhausted and tired. I mean, these kids tend to really need less sleep. Parents may find them, up watching TV or playing video games in the middle of the night. Flight of ideas mean that children feel like their thoughts are going so fast and they really can't turn them off. So this is often described as kind of racing thoughts. And racing thoughts will often result in what we call pressured speech, which essentially means that children talk really loudly and really rapidly, sometimes almost spitting out their words. Others may describe them as difficult to understand or follow. So what I want to point out and what I think is really important here is thinking about intensity and episodicity. So I think all parents could probably provide examples of their children engaging in behaviors like this. I mean, we know kids tend to be a little grandiose, they have a lot of energy, they get really excited sometimes, and it's not pathological, it's perfectly developmentally appropriate. And it's true that in many ways, mania is just an extreme version of normative behaviors and normative mood. The key to determining whether a child may be experiencing clinically significant mania is to assess whether these symptoms, happen all together and whether they represent a distinct difference from the child's normal functioning. And then finally, whether they cause distress and impairment. So in order to diagnose mania, these symptoms must reach a certain threshold for severity and intensity. They must last at least 1 week and represent a clear change from the child's previous functioning. And finally, they must cause significant impairment in the child's daily life and ability to function. So that could mean their ability to do well at school or to interact socially. So the diagnosis of mania requires, as I said, either expansive or irritable mood as kind of the core mood feature of mania. And here on this slide are some examples of what expansive or irritable mood might look like in children. So expansive mood often manifests as extreme, over-the-top excitement. So just extreme excitability, children being silly and giggly nonstop in ways that are totally out of proportion to any trigger. Constant joking, kind of always being on the go, feeling invincible. Parents and others will often describe these children as being completely exhausting and overwhelming to be around when they're in this state. When experiencing irritable mood, or kind of the manifestation of mania that is irritability, children will be aggressive, abrasive, hostile. They'll be extremely quick to anger, and their angry responses will be intense and very over the top, very extreme, severe. They will often scream, curse, threaten. They may become physically aggressive, throwing furniture, kicking through walls. Parents will often describe their kids during these episodes as intense and inconsolable. Again, their reactions kind of totally out of proportion to whatever the stimulus was. So, for example, having a 2-hour rage episode in response to finding out their favorite TV show is not on that night. So I do just want to take a moment to expand a little bit upon these rage episodes that are associated and are very often kind of a core feature of PBD. Rage episodes are extremely common in pediatric bipolar disorder and are often the main presenting issue that parents come to therapy with because they're extremely disruptive and very concerning to parents and the family system and really get in the way of the child's ability to function. I often get asked the question of, how how are these bipolar rage episodes really that different from temper tantrums, which we know is a very normative, developmentally appropriate behavioral, pattern of childhood. And what I always say is unfortunately, it's kind of hard to describe unless you've really witnessed one. But essentially, the difference is really in intensity and length. So these rage episodes will be incredibly intense, with inconsolable crying, screaming, often verbal and physical aggression, and they may last for an hour or more, again, during which the child is completely inconsolable and really can't be redirected, can't be soothed. When you see a child having one of these rage episodes, you really get the sense that this child has truly lost control and kind of has no ability to modulate their own emotion. Afterwards, once the rage episode has kind of run its course, these children will often be very sorry and remorseful and talk about how they, lost control of their brain or a monster took them over. So that's kind of how they experience it, is almost as if they're having kind of an out-of-body experience or kind of have no control over their emotions. So these rage episodes really are one of the most problematic manifestations of mood dysregulation and end up being a major target for treatment. So in order to be diagnosed with bipolar disorder, a child also needs to have experienced a depressive episode. That means that for at least a 2-week period, they exhibited consistent depressed mood, so being sad or really down almost all day, every day. And sometimes depression in children actually looks more like irritability than it does sad mood. And then in addition, they have to have experienced 5 or more of the other symptoms that are listed on this slide. So diminished interest in activities that they used to like. So an example would be, all of a sudden not wanting to play soccer or be in the band when that used to be one of their favorite things to do. Significant weight gain or weight loss, sleeping either too little or too much. Psychomotor agitation or retardation, which essentially just means their body movements are either kind of faster than normal or slower than normal. Fatigue, loss of energy, feeling worthless or having lots of guilty feelings, difficulty concentrating, and recurrent thoughts of death or suicidal thoughts and behavior. And again, it's important to note that these behaviors must represent a significant change from their prior functioning and really be severe enough to interfere with their ability to function. So when thinking about treatment for PBD, it's important to understand kind of the science and what we know about this disorder. And I like to think of the science informing pediatric bipolar treatment kind of in 3 main areas. And these are, what we know about the unique characteristics of pediatric bipolar disorder, so both compared to kind of other childhood psychiatric disorders, as well as compared to bipolar disorder when it presents in adulthood. 2, what we are learning about what's happening in the brain that might actually help explain some of the symptoms and difficulties that kids experience. And then finally, what we know about the psychosocial and interpersonal difficulties that accompany the symptoms. So I'm going to discuss each of these areas over the next 3 slides. Part of the reason that there's been so much controversy, I think, and misunderstanding about pediatric bipolar disorder in the past is because it tends to look a little bit different than adult bipolar disorder, which can make it really hard to diagnose. First of all, because we're still using DSM-5 criteria, which were really made for adults to diagnose pediatric bipolar disorder. But also because it really does, it just tends to have, slightly different symptoms and symptom manifestations and symptom characteristics than when these symptoms present in adulthood. So it does make it really important to have a clinician who is knowledgeable about pediatric bipolar disorder and really specializes in this area. So on this slide are a few of the characteristics that are unique to pediatric bipolar disorder. When mania and depression presents in children, how it presents differently. And we don't actually yet know why it presents differently in children. I mean, it may have something to do with different stages of brain development, so the brain being kind of underdeveloped in particular areas, children having fewer cognitive abilities and coping skills than adults. Or it's possible that when mood dysregulation, associated with bipolar disorder, occurs in childhood. It just involves slightly different pathways in the brain that result in different symptoms. There's a lot of great research being done that hopefully will help give us some answers to those questions. But as of yet, we don't know exactly why this is the case. But we do know that children with bipolar disorder tend to exhibit extreme mood lability. So their mood may fluctuate from irritable, excitable, impulsive, intrusive, and loud to sullen, withdrawn, and weepy, all within the course of a day. So they're often described by their parents and others as just being incredibly moody. We've already talked about the rage episodes, which tend to be unique to bipolar disorder in childhood versus adulthood. Children tend to cycle between symptoms of mania and symptoms of depression multiple times per day. So we call this ultradian cycling. Essentially what that means is that they're cycling on average at least once a day. And this is much more frequent than the episodes that are usually observed in adult bipolar disorder. And it's another reason why it can be difficult to diagnose because, the criteria for bipolar disorder really requires that there be discrete episodes that can be identified. But episodes can be really hard to identify when kids are fluctuating so rapidly and the cycles are just occurring so rapidly. As a result of this rapid cycling, children will also exhibit symptoms of depression and mania at the same time. For example, they may describe feeling worthless and sad while also appearing irritable, hypersexual, and impulsive. Again, because they're fluctuating so rapidly, symptoms of mania and depression are kind of superimposed on one another and can co-occur. And finally, children with bipolar disorder often meet criteria for multiple other disorders. The most common ones are ADHD, oppositional defiant disorder, and anxiety disorders. It's often the case that they get diagnosed with one of these disorders first, and only after treatment fails does an underlying bipolar disorder get recognized and diagnosed. So brain science is a rapidly advancing area. Functional MRI and other neuroscientific technologies are allowing us to actually look at the brains of children with bipolar disorder and the brains of children without bipolar disorder, while they're engaging in different tasks and really see kind of what's going on functionally, at the brain level. And this really helps us better understand how the brains of children with bipolar disorder might work a little bit differently. The science is very complicated, as you can imagine, but essentially, one of the things we do know is that the areas of the brain related to problem solving tend to be underactivated in kids with PBD, and the areas of the brain related to emotionality and emotional expression tend to be overactivated. So what this means is that when faced with any sort of emotional stimuli or emotionally charged event or situation, children with bipolar disorder exhibit a decreased ability to problem solve and excessive emotionality. So this, I think really might help explain some of the symptoms that we see, the rage episodes, the mood swings, and some of the psychosocial impairments that we see in these children. And finally, we know that children with bipolar disorder experience many interpersonal and environmental stressors associated with their symptoms of mania and depression. So these include peer rejection, lots of conflict in the family system, very low self-esteem and feelings of worthlessness, exhaustion and strain in parents, and problems with school and academic functioning. So before I jump into describing our rainbow treatment in particular and some of the tools that I think might be helpful, I wanted to touch upon the need for psychosocial treatment alongside medication when treating PBD. So there are many psychosocial impairments associated with bipolar disorder listed on this and the previous slide. And we know that while medication may help stabilize mania and depression, it will not necessarily go a long way in addressing some of these other psychosocial issues. In addition, medication treatment is complicated by really high rates of non-response, lots of negative side effects. Parents are often very understandably reticent to put their kids on these very potent psychotropic medications. So therefore, psychosocial treatment is really considered a necessary component of treatment and should be delivered by someone with experience and specialty in pediatric bipolar disorder or children with mood disorders. despite the fact that it's recognized as an important treatment component by the American Academy of Child and Adolescent Psychiatry and other organizations. Unfortunately, very few psychosocial treatments for bipolar disorder in children have been developed and rigorously tested so that we know that they really work and are more effective than other treatments. There are a couple. One of them is our Rainbow program, which I will be describing a little bit. But what research has been done on psychosocial interventions tends to kind of highlight some important elements of treatment. So these are things you would really want to be looking for in getting effective treatment for pediatric bipolar disorder. One is that it's family-based treatment. So in other words, it doesn't just focus on individual work with the child, but actually involves the parents and the entire family system in the treatment delivery. That it includes education about bipolar disorder. And that it includes both cognitive behavioral and interpersonal psychotherapy techniques. So in other words, that it includes a focus on educating the family, on addressing thoughts and feelings in a very structured way, and in teaching kind of interpersonal coping and problem-solving skills. In addition, it's important that psychosocial treatment focus on other systems that might be important, I think most notably for children, the school system. So Rainbow, which is also called Child and Family-Focused Cognitive Behavioral Therapy, is a treatment that we have developed specifically for children 7 to 13 with a bipolar spectrum disorder. So we developed the acronym Rainbow to indicate that what we consider to be the 7 core ingredients that we really believe are important to treat pediatric bipolar disorder. So I'm going to talk through each component and give some examples of interventions that could be helpful if your child has bipolar disorder or has any problems with moodiness or emotion dysregulation. So starting with R, the R of Rainbow equals routine. So we know that these youth experience severe mood dysregulation, and evidence has shown that disturbances in routine or lack of structure in the child's daily life can really trigger or intensify mood dysregulation. So the goal of this component is to improve mood regulation and decrease symptoms through establishing very predictable and simple routines for the child and the family. So some of these routines may include sleeping, routines around sleep, around diet, taking medications, and dealing with transitions that occur in daily life. We know that transitions are very difficult for kids with mood dysregulation or bipolar disorder. Transitions meaning getting up in the morning, getting dressed, getting ready for school, transitioning to the school bus, transitioning home after school. These tend to be kind of major triggers for mood dysregulation and can be important to kind of come up with ways to establish routines around dealing with transitions. But an example, in terms of some of these other routines, I think sleep is number one. That's always the first one I go to with families because sleep is so important in terms of regulating children at both the psychological and biological levels. So children really should go to bed and wake up at the same time every day. This really helps regulate all of their bodily processes, including emotion regulation. And children and parents can work together to create sleep diaries or charts to help track sleep and really work towards establishing a good, solid sleep routine that enables a child to be getting enough sleep per night and enough quality sleep. In addition, we found that adding soothing and release activities into the child's daily routine can be helpful. So soothing activities are designed to soothe the child's nervous system. So things like listening to quiet music, taking a bath, reading with a parent. Release activities are kind of the opposite, so activities that are designed to help children burn off some of the excess energy that they might have, such as playing sports, going for a walk, or even playing at the playground. And, what I like to tell parents is that, a lot of parents kind of use some of these things in a more reactionary way to, if the child is appearing dysregulated, then maybe use either soothing or release activities as a coping mechanism. And that's great. That's fine. But it's also, I think, can really be helpful to proactively incorporate these activities into the child's daily life because it helps keep their nervous system, the baseline, lower, and makes them less likely to kind of be susceptible to triggers and for dysregulation. So it can be really important for parents to find ways to make these routines predictable and consistent for their child, but also to help them remember to keep with these routines. So using posted reminders, posting routines and calendars and schedules around the house and central locations, giving warnings to help children anticipate transitions or changes, and then really planning ahead to avoid disruption in the routines. So the A is for affect regulation, and this is really grounded in what we know about brain function in PBD and difficulties with mood regulation. So the goal here is to help develop appropriate behavioral management strategies for the parents to use, and help the child and parents and the family together to develop coping strategies to compensate for some of these difficulties in emotion regulation and problem solving that these kids have. So treatment focuses on, first helping the child to understand their feelings and how it relates to what's going on in their brains and at the brain level. So it can be really important here to provide education to families on the biological underpinnings of the disorder, with the goal of helping parents really understand that this is a brain disorder. It's not their child being purposefully or willfully difficult. And we find this knowledge really can help change some of the negative family dynamics that might have developed, around kind of blaming the child or feeling like the child is being manipulative or purposeful, and help the family to really approach managing these difficulties in a more empathic and kind of proactive way. In addition, self-monitoring of moods is a very important skill to learn. On this slide is an example of one of our mood monitoring forms that allows the child to kind of rate their mood each day using different colors for different emotions. And this really helps us to begin to identify patterns in mood dysregulation and what the particular triggers are for mood difficulties. So are there particular times of day, particular interpersonal interactions, particular situations that are really triggering some of the dysregulation. And finally, it's important to develop coping skills to prevent and manage these difficulties as they come up. So parents, can work with their children and a therapist to develop coping plans for whatever the various triggers are. For example, some common triggers that we always see include, sibling and sibling relationships, homework, being told no is a big trigger. And so developing kind of step-by-step plans for what to do in the face of these triggers and when these situations do occur can be very helpful. Families may also develop coping plans for rage storms, for these rage episodes that we've been talking about. This might include a step-by-step plan for reminding themselves about the biological difficulties their child is facing, trying to remain neutral, helping soothe and de-escalate the child versus engaging in behaviors such as yelling, threatening, or punishment that actually just serve to make the rage worse and make it go on longer. So we often help families to understand this as kind of putting out the fire. So during these episodes, they want to be pouring water on the fire through soothing and coping versus fanning flames through kind of limit setting and punishment in the moment. So this is a great example of one coping strategy developed by one of our patients. This child created a cool-down corner in her room. She called it Sam's Snow Cone Corner. And she equipped it with all kinds of stuff that she felt like would help her cope and calm down. Lists of coping strategies, soothing images, favorite toys, paper and her colored pencils to draw. And so her coping plan was that when she began to get upset, she would go to her corner and she would use these strategies to soothe herself and to help cope with whatever intense affect was coming up, in an attempt to kind of stave off a major escalation into a rage episode. So the I in Rainbow is I can do it. This is our self-esteem building component. So data and evidence suggests that self-efficacy plays a really important role in the management of mood episodes. And also we know that these kids tend to present with very low self-esteem. So the goal of this component is really to increase the family's belief in their ability to cope with the disorder and also to improve self-concept in the child overall. So here we draw on some more traditional CBT techniques as well as mindful approaches to parenting. So with the parents, we really work on recognizing their child's strengths. So a lot of times, they become so focused on what their what's not going right or what their child is doing wrong or all of the difficulties and challenges that they've kind of forgotten, what they love about their child and all of their child's wonderful, strengths and positive qualities. We also work with parents on finding opportunities for success or mastery experience for their child, building on their strengths to kind of put them in situations where they're going to feel good about themselves. Coaching parents on giving consistent positive reinforcement. Again, the tendency has been to kind of develop these patterns of lots of negative reinforcement, what the child is doing wrong and trying to redirect their behavior, but not a lot of positive reinforcement when they are actually doing things well. We also help the parents to develop their own positive mantras about their ability to cope, which can kind of help them and bolster their own strength in these situations where they're kind of having to draw on their skills and coping strategies to help with their child. Work with the child focuses on identifying their child's positive qualities, which is often quite difficult for these kids. Again, they've experienced a lot of negative feedback from peers, from teachers, from parents, and they tend to feel very bad about themselves and have very poor self-esteem. So we really want to focus on their positive qualities and strengths and help them to develop an identity that's separate from their symptoms or their disorder. So they are not their bipolar disorder. They're a child that happens to have bipolar disorder but also has all these other wonderful qualities and identities. And we help the children to develop kind of positive scripts and mantras and various different skills to kind of manage these difficulties and remain positive in the face of challenge. So N has double meaning, no negative thoughts and live in the now. We know that mood disorders are associated with negative or distortive thoughts and beliefs about self, others, and the future. So the goals of this component are twofold. The first is to decrease the negative thinking patterns in both children and their parents. And then the second goal draws on mindfulness-based intervention and literature on incorporating mindfulness interventions into CBT to really encourage a focus on coping in the present moment and to avoid becoming overwhelmed by thoughts and predictions that extend out into the future. So this part of treatment involves really more traditional CBT approaches for recognizing and reframing negative thoughts that increase distress, along with some mindfulness-based techniques for parents. So mindfulness techniques help parents to focus on the present moment through breathing, through practicing non-judgmental acceptance of their thoughts and emotions, and also practice ways of approaching their child with more calmness and more compassion through building empathy, taking their child's perspective, and kind of bringing their full attention to whatever present situation it is that they're dealing with. And we found that these skills can be very helpful to parents to prevent them from feeling overwhelmed and really help them to cope with their children's difficulties more effectively. Parents can be reminded to use these skills through developing mantras, again, self-scripts, and just ways to kind of prompt themselves in the moment to remind them to use their effective, their good coping skills. So B is, again, a two-part component. As discussed, children with PBD often have significant social difficulties. So the first goal here is really to improve social functioning in children. But we also know that parents often experience their own significant stress and strain. So a second goal is to enhance parental self-care and increase the extent to which there's balance in their own life. So these goals are addressed through work with both the parent and the child. With the child, we focus on developing skills for making friends and communicating effectively with others. Parents are encouraged to seek opportunities for their child to practice their social skills and to develop positive relationships and good friendships. And then in addition, parents are helped to find a healthier balance between the demands of caring for a child with PBD, which are significant, and taking care of themselves, making sure to build in time for themselves, for self-care, for time with friends, for exercise, for pleasurable activities. And this is an example of an activity that we do to work with parents to kind of move towards achieving a more balanced lifestyle. So we have them complete 2 pie charts. The first describes their actual time spent doing activities like chores, childcare, errands, and then the second describes their ideal allocation of time. So were they to be their best, kind of most relaxed, most optimal self, like how would that pie chart look different? And then we help to work with them, sometimes slowly, but to really work with them to find ways to begin to redistribute that pie chart and to move more towards their ideal situation as a way to really help improve balance and self-care and nurture themselves, because we often say that they cannot be a good parent to their child unless they're good to themselves first. So the next component focuses on building problem-solving skills in the child and family. As we know, these skills are very impaired in these youth, and that these families tend to experience a lot of stress and conflict in the family system. So as part of this component, children are taught problem-solving skills and how to apply coping skills to new situations. We work with the entire family system in this component, including siblings. And really talk about the current patterns of communication and problem solving and how we can move towards more positive and effective ways of problem solving at the family level. So one of the most important things I think to remember with regard to problem solving in family systems where there's a child experiencing extreme mood dysregulation is the timing and the tone of these interactions. So we really help parents to try new ways of problem solving that involve discussing difficulties during calm periods rather than in the heat of the moment. So the impulse is always to want to kind of solve whatever is going on right in the moment, to set those limits, to implement those consequences and punishment. But we know that this unfortunately just does not work well with kids with bipolar disorder and tends to just fuel their rage and their dysregulation and make things worse. So we really emphasize using a collaborative and empathic approach to problem solving that involves being proactive, so really planning ahead, kind of knowing how the steps that are going to take place when one of these episodes occurs, versus being reactive and just waiting till something happens and then trying to figure out what to do in the moment. One thing that we often do with families that we find is a really helpful technique is what we call the family bug box. So bugs are in our treatment what we call our triggers. So triggers, we have our kids call them their bugs and identify what their bugs are. So families create a family bug box. This is literally like a shoe box or some other sort of box that they locate somewhere centrally in the house, like in the kitchen or the living room. And throughout the week, parents and children are encouraged to put little pieces of paper into the box that describe triggers, problems, difficult situations that they experienced that week, or things that upset them. And at the end of the week, when everybody's calm, they all sit down together as a family and goes through each one and kind of uses their problem-solving techniques to come up with resolutions for those triggers or situations. And that's a really great way to practice and to kind of really strengthen that muscle of using these more kind of effective and collaborative ways of solving problems. And finally, it's very important to focus on ways to seek support. We know that stigma, isolation, lack of access to resources very often prevent families from finding or using positive support networks. So the goal is really to increase access to support systems for the child and family, teach them really what it means to have positive support and how to identify and access that when it's appropriate. And then in addition, how to kind of be an advocate in other systems, most significantly probably the school system. So we have both parents and children complete a support tree activity. That's on this slide. You can see they actually literally draw a tree. Each branch is a different system: school, social, family, healthcare. And then they kind of list out or really identify their positive sources of social support in each of these various areas. And these really serve as a great visual reminder of those that are in their support network. School consultation is a really important aspect of making sure there's good support in place for the child, since this is where children spend the majority of their time. And therapists and parents can work with the school personnel to help educate them about bipolar disorder in children. I mean, very often there's very little knowledge that school personnel have about bipolar disorder, but really about mood disorders versus kind of behavioral disorders or ADHD that they might be a little bit, more used to seeing or a little bit more familiar with the techniques that are used to manage, behavior problems in the classroom. But we often find that teachers and school personnel really don't have a lot of knowledge about mood disorders and how they're different. So I think working with the school system to ensure that there are appropriate adaptations and supports in place to deal with, whatever emotional or learning issues might arise is really important. And then to facilitate communication between the parents and school. So in conclusion, my goal for today was to provide some education about how to recognize bipolar disorder in children and some useful tools and interventions to address symptoms. If you believe your child may be bipolar, or if your child has any sort of, emotion regulation difficulties, whether or not it's bipolar, it's really important to seek out a clinician, I think, who specializes in pediatric mood disorders, or if not, at least has some experience and is willing to get consultation if necessary. At the end of the day, children with PBD and their families need the same things that we all need when facing difficulties or challenges in life. They need education, they need support, they need understanding, and then they also need tools and strategies and resources. But most of all, I find that they need encouragement and hope that there is help. PBD and mood difficulties in children are a real thing, with real underlying biology. So it's no one's fault. Children are not at fault because they have difficulty regulating their emotions, and parents are not bad or incompetent because they don't know what to do. There are really good treatments that have been researched that we know can help children and families manage these symptoms and impairments and restore a sense of peace and balance to the family system. So I will go ahead and stop there, and I'm happy to answer any questions.
Thank you, Dr. West. That was incredibly helpful and informative. I think there's a lot of misconceptions about bipolar disorder. Certainly we have a lot of very good questions to begin. So let me just start with a question here about whether there are gender differences in how mania manifests, whether it's expansive versus irritable.
Yeah, what the research has shown is that in younger kids, there really aren't as many gender differences as we see sometimes with like unipolar depression in adolescence, say, or in adulthood. The symptoms tend to be the same in both girls and boys. I mean, it sometimes can seem hard to believe, but because I think that the notion is that, maybe boys act out more and you see more of the kind of aggressive, hostile, irritable mood, and girls might be, less aggressive, and you might see it manifest more in expansive or elevated mood. Clinically, I haven't really seen that to be the case. I mean, I've had plenty of girls who have extreme rage episodes, and lots of behavioral, outbursts and kind of behavioral manifestations of their dysregulation. So I haven't seen as much of a differentiation by gender, but I'd say more so it's just individual. It is the case that there's lots of heterogeneity in bipolar symptoms. So whereas one child might be more internalizing, might have mood dysregulation, but really manifest it more in sadness and withdrawal and irritability, and another child might be extremely rageful and hostile, so it's really more kind of differences at the individual level versus specific to gender.
Okay. And what about there's a question about irritability, specifically the symptom irritability during a depressive episode versus during a manic episode. Is there a difference in the energy or the duration or the intensity of the irritability that you see during depressive versus manic?
Yeah, that's a really great question. I think, when it's part of mania, first of all, it will be associated with a lot of those other mania symptoms or some of those other mania symptoms. So that can be kind of a helpful way of differentiating, what's depressive irritability and what's manic irritability. But I think it also tends to be just much more intense and severe and kind of be associated with these rage episodes and with just lots of dysregulation and behavioral outbursts and hostility and aggression, whereas irritability that's part of depression, it just tends to, this isn't a very technical way of saying it, but it's a little bit quieter. It's really a little bit more about just kind of this chronic low-level, quick to anger and just feeling irritated and annoyed and frustrated, by things that are occurring versus really having a high level of aggression.
Okay. One question the question of differentiating between bipolar and other disorders always come up, and we have a question here about how differentiating between a child with rage attacks and OCD, kind of a mixed bag of rage attacks and OCD or co-occurring other kind of impulse control disorders or things like that. How would you go about differentiating those?
Yeah, so, I'll often say that the rage episodes, while they're very kind of primary and characteristic of bipolar disorder, are not necessarily distinctive. We know, as the person who answered this or asked this question is indicating that rage episodes do occur in the context of other disorders. So, there I think it's always a matter of kind of taking a bird's eye view, so really looking at what other symptoms is the child experiencing. And often, it can be kind of often most difficult to kind of differentiate like ADHD and ODD because there's a lot of overlapping symptomology. So what I'll often say is we want to look for some of the symptoms that we know are actually unique to bipolar disorder. So some of the mania symptoms, stuff like hypersexuality or racing thoughts, pressured speech, things that really we don't see appearing as much in other disorders. So that's one thing. I think another thing I'll often look for to differentiate is the level of episodicity. So a lot of these other disorders, ODD, ADHD, tend to be more chronic. You really don't see these kind of discrete episodes occurring. And by definition, bipolar is a disorder of episodes, of episodicity. So that can be another helpful way to try to differentiate it from other more chronic disorders, is to really try to delineate whether there are episodes occurring that are really a significant change from baseline.
So the episodic, the kind of the cyclical, the ultradian cycling would be something that might be helpful in differentiating.
Yeah. Cycling in general. Cycling doesn't. There are other disorders that are episodic, but I think the kind of cycling you see in bipolar disorder is pretty unique, and particularly when it occurs along with other symptoms that we know are specific to bipolar, like certain mania symptoms. Then I think that that would lead me more towards thinking about a bipolar diagnosis versus something else.
Okay. And with the Rainbow program, are there teachers involved in the intervention? I know there's school consultation, but are they folded into some of the skills strategies, or is there kind of a structure for that, or is that just something that is kind of adjunctive?
Yeah, it's adjunctive. It's not a formal aspect of the intervention per se. Teachers don't come to our clinic necessarily and participate, in the treatment. But it is, it's always part of what we do clinically, as part of the treatment. There are rare cases where children really aren't experiencing, a lot of difficulties in schools where it's relatively well managed, and then we might not interface with the school as much. But I'd say that's much more the exception than the norm. And usually we are. And I'd say, what that looks like more typically is that we will, be in contact with the teachers at the school. We may provide, recommendations for particular adaptations. I've gone out to schools and done in-service training and done psychoeducation about mood disorders, to help kind of educate teachers and school personnel about mood disorders and the kinds of adaptations that are necessary. So will sit in on IEP meetings, for individual educational plans and help provide psychoeducation and recommendations. So those are the sorts of roles we play as clinicians. It's not necessarily a formal aspect of the Rainbow program, but it's always something that we're doing.
Mm-hmm. Okay. And another question is about pediatric bipolar disorder. Does it continue into adulthood? What, even after receiving this intervention, what should a parent expect?
Yeah, so that's another really good question. There's a couple things I want to say. The first is that unfortunately we don't have a lot of good longitudinal data yet. This has really only been a diagnosis that's been made in like the last 20 years, so there aren't a lot of really long-term longitudinal follow-up studies. There have been a couple, though, and the one that I'm most familiar with that kind of followed kids from early childhood up through early adulthood, so into their early 20s. And essentially, what they found that was interesting was that it's not this kind of distinct presentation, that child have, the ultradian cycling, the comorbidity, the rage and irritability, tends to continue into adulthood. So it's not that, when kids become adults, they kind of morph into the adult form of bipolar disorder. They really kind of tend to continue to have this unique presentation, which, I think says to me that either it's, maybe a slightly different form of bipolar disorder or potentially just a more severe presentation or manifestation of it, when it presents early in childhood. So that's the first thing I wanted to say. The second thing is, regarding kind of what the expectation should be after treatment. We don't have a cure for bipolar disorder yet, and it's a chronic illness, and it, like asthma, like diabetes, it's not something we can necessarily eradicate yet. But we also know that there are really good treatments, both pharmacological and psychosocial, and so I think the idea behind Rainbow is kind of to really give parents kind of an acute dose of all this education and all of these skills and all these strategies, with the notion that they'll kind of continue to try to incorporate those strategies into their daily life over time as a way of kind of managing the disorder long term. Now, there are going to be episodes, there are going to be, hard, difficult periods and periods where symptoms, pop back up and, and things get really hard again. It's a chronic disorder, it's an episodic disorder, but the idea is that, those will be much better managed because parents and families have these skills, and that eventually over time, hopefully they won't be as severe and they won't be as intense, and there'll be longer periods in between, and that the family and the child will be just much more empowered to know how to deal with that mood dysregulation when it does kind of occur and pop up again.
Well, I think that's all the time we have for this webinar. So thank you so much for telling us about recognizing pediatric bipolar disorder. And I want to thank all of the attendees for being a part of this webinar, and we hope it was helpful. Please let others know about this series, and there are lots of other wonderful topics up in the calendar for upcoming months, and please consider making a contribution to ADAA. Once again, thank you, Dr. West, and we hope to, be able to make an impact through this webinar. Thank you.
Yeah, my pleasure. Thank you.
Thank
you so much for the opportunity.
Bye-bye.
Bye-bye.